one combination will be interesting, maybe for our BRCA patients, will be a PARP inhibitor with a checkpoint inhibitor. That would make a lot of sense, because we want to try to probably use the PARP inhibitors as soon as we can in the natural history of the BRCA1/2 patient population, and so, but we also, if they're PD-L1 positive, we want to be using checkpoint inhibitors too, you know what I mean? So Adam, just bring us up to speed a little bit on where we are with PARP inhibitors.
So there are two randomized trials that we have. There's Olympiad and there's Embraca. They both basically are very similar, both in their design and their outcome. In Olympiad, I think it was about 302 women with BRC, germline BRC-associated breast cancer, in second-line therapy and beyond. And they were subgrouped as to whether they were triple negative or ER positive or prior platinum. Were randomized to physician choice of chemotherapy, which is the typical things we use second line in triple negative and ER positive breast cancer, or olaparib. And in the olaparib arm, the PFS overall, I think, was about 7.5 months versus, I think, about 4 to 5 months. It was an improvement about almost doubling, not quite doubling, if I'm not mistaken. And basically, the women who had prior platinum did not have as good a response. Women who were triple negative had a better PFS delta. So those seem to be the subgroups that did better. There was no survival benefit as far as I know in that trial. And interestingly enough, the side effect profile was very similar to the chemo, with the exception of hand-foot syndrome from capecitabine, which was more. And alopecia. Well, there was really no alopecia in that because there were not alopecia-containing chemos. So Embraca was a very similar design, although it allowed first-line patients. I think about a certain percent of patients, I think it was 40% or something, was first-line in Embraca. And it was very similar. Again, it was talazoparib versus physician's choice of chemotherapy. And the PFS, I believe, was a little over 8 months in the talazoparib arm, and I think a little under 6 months in the control arm of physician choice of chemotherapy. Those numbers were a little bit higher because they included the first-line patients. And the other thing that seemed to be very interesting, it looked like there was a trend toward overall survival with talazoparib, if I'm not mistaken. It wasn't statistically significant, there weren't enough events, but basically the bottom line is those two trials are very similar, both in their design and outcome.
I will say, for the Olympiad study, the primary author, Mark Robson, presented at AACR some subset data on outcomes and survival. So the curves in folks that did get treatment, I think first and second line, had an improvement in overall survival. Granted, it's a subset and
it's smaller, but no, I agree with you. So I agree with you. So I'm saying that it's only a trial design issue, I think, more than anything. I think that there probably will be a survival benefit. But here's the issue. So let's get back to the question you asked. So someone comes in, you're one of those 8 to 10% of women who come in who are PD-1, L1 positive, and BRCA positive.
Germline BRCA.
Germline BRCA. What do you do? Which you treat first? And I think that, a lot of us have been talking kind of on the sidelines of this meeting about this. And I think that there's a clear survival benefit to the first-line therapy with atezolizumab and chemo. There may be a trend, and the other thing that happens is that there does seem to be benefit in later lines with the PARP, where there was not benefit in later lines with the IO, at least for now. So for me, based on those two kind of observations, I think I would do in that double positive person, I think I would give her IO first. I think I would give her chemo and IO first.
I think the survival benefit makes that really a...
But there's probably going to be a survival benefit too. I think we look at the data longer with PARPs.
The longer, maybe.
But I agree with you. I think the survival data really does make that the reason to give it first.
And the subset of the first line in Olympiad, the first line, the subset that Mark Robson put at AACR, it's a statistically significant improvement in survival with olaparib compared to chemotherapy in the first line. So it's stat sig, it's just that it's a subset. It's a subset analysis.
So which one do you use first?
Well, for the triple negative, I do like to use the PARP inhibitor because we've had those, you know what I mean? We haven't had the checkpoint inhibitor yet, but I've been using the PARP inhibitor first line, for triple negative patients.
But now you're going to have a checkpoint inhibitor. What are you going to do?
Well, there are safety data. There are safety data combining checkpoint inhibitors with PARP inhibitors. There's the Mediola trial. The DORA trial is ongoing, combining PARP inhibitors. There's actually there's a Topaccio trial too, so there's a number of data sets now not surprisingly, there's not a lot of surprising toxicities, with
Right, they were
that.
expected.
Yes, yes, yes.
We also need to just keep remembering the eligibility criterion for all these different trials. So for the PARP, those patients, while they might have had prior exposure to a platinum, they could not have progressed on a platinum. And we have to remember in the adjuvant setting and neoadjuvant setting, a lot of these patients are getting a platinum potentially. We have to remember the disease-free interval on a study like Impassion. Sure, there'll be more coming, but I'm hoping that some of those characteristics might help in deciding for those few patients that have both biomarkers,
Yeah.
which way to go.
But if I took out the crystal ball, and albeit we need more data, but if I took out the crystal ball, I think the PARP inhibitor first line plus a checkpoint inhibitor would end up being a reasonable way to go for patients.
And I would just point out, to add to Adam's comments, that it's these exceptional responders. So it's the promise of durable, sustained responses with immune therapy. And so that's really the promise. And we all have a handful of these patients in our practice with triple-negative breast cancer who are more than a year out. I have some that are more than a year out, not on any therapy, they're NED. I think a lot of us have those patients now. And so that's the embodiment of the hope that this offers.
And were they mainly first-line patients, Heather?
Not necessarily patients that I've treated on trial that have been heavily pretreated who, we've
When you
looked at
respond,
other.
you respond for a long time. I would agree with that. But here's the question. Why didn't we ever use PARP inhibitors like do in ovarian cancer? Look at the SOLO trial that came out where they basically used olaparib maintenance and have a PFS of like years, like 3 or 4 years. Why didn't we do that?
Dora looks a little bit at that question because
little
they're
bit.
using platinum as a sort of a surrogate for response to a PARP and then use the PARP as maintenance. But I think we have to remember breast cancer is not ovary cancer, right? You have
But it is
responses
being
even
This
in
is
the
maintenance,
outside.
right? Hopefully. And we have all these kind of creeping around, these trials of like chemo maintenance for years that show a survival benefit that we always ignore because they're just chemo. I mean, there may be something to this in breast.
Just
I don't
to
know.
clarify too that the DORA trial used the platinum to select for responders, but then it's not just, it's olaparib with durvalumab, so incorporating both.